Thank you very much. It was a most fascinating journey for past 1.5 hours. And seeing Dr. Shanti and Dr. Gurumurthy and Dr. Varun, it was like a deja vu phenomena for me. Because exactly 20 years back, I came to Minnesota, and it thanks to Dr. Elizabeth Bronlin, who inspired me to come to Minnesota to get trained as a pediatric cardiologist. And you people are doing such wonderful job. And I remember the great giants like Lily High and Kurt Amplatz and Edwards, and they laid the foundation. And you guys are building the castle on that. And a great congratulations to all of you. And Shanti, your epicardial echo was a wonderful presentation. And the linear transducer, does it have the 3D or the 4D? And how do you sterilize? And what is the rate of infection?
Very good question, Vijay. Thank you very much. I still remember fondly when you came to Minnesota 20 or 25 years ago. Peter Hessline introduced me to you. It's a pleasure. It's a pleasure to be part of this wonderful conference. Epi-aortic, epicardial, so there are two different scenarios. I use epi-aortic as a linear array transducer. It's very easy to sterile. Again, it's very limited. It's got only 2D, and the color spreads quite a bit. It doesn't have a 3D capability. It's a vascular probe, basically. So I had utilized that for coronary artery scanning. And the sterility of it is the same as what you do for your TE probe. You just have to have that formalin prepped as much as you can for at least 15-20 minutes prior to it. I just want to answer two other questions, if you guys will let me. Since I brought up the linear array transducer, there were two questions about the blind spot in the aortic arch and the low-lying coronary arteries. Just to give you an example of epi-aortic can be utilized and epicardial can be quickly, the surgeon can place it on top if you're looking for aortic dissection. It takes less than a minute. Put the probe on, ask the surgeon, and I usually scrub in with the surgeon. Really, they don't scare me. I just want to let you guys know, just go and quickly take a picture and you can get a lot more information within less than a minute. Thank you.
Thank you, Shanti. In fact, when I saw the pictures of tetralogy of Fallot, I was reminded of Dr. Puga, who used to operate on 3-day-old Toph, and I was amazed at the way he was doing in the Mayo Clinic, and that was amazing. And Dr. Naveen Kumar has a question for you. He wants you to describe how do you manipulate the probe to get the different views.
It's very simple. Always point to patient's left shoulder. It's a very startle moment in pediatric patients. Adults move a lot, but pediatric patients, your field of operation is very limited. So you go straight, place the marker, your marker of the probe has to point to the patient's left. And then go anterior, posterior, slightly tilting leftward. This is all the technology you have. You don't need any fancy hand movements at all. It is patient to the left, to the shoulder, anterior, posterior tilt will get you the results within less than 2 to 5 minutes.
Thank you so much, Shanti. It's a pleasure seeing you after 20 years, and you haven't changed much. You look the same, and you're doing a great job. Congrats. And Dr. Gurumurthy Hiremat, it was a pleasure hearing you about the intracardiac echo. The first time I saw the intracardiac echo, the ICE was in Chicago when I was getting trained with Zia Hijaji. And one, Dr. Chi, he's the anesthesiologist who is to help him a lot. And especially, while putting the fenestrated ASTs and putting two devices like sandwiching between one in the other one, like the larger one and the smaller one, and he used to handle it so nicely. And I'm sure, that is the way you guys are doing. And apart from that, even for the PFO, where there is a tunnel-like PFO, this ICE is very useful. And I wish ICE has already come with the 3D and the 4D pictures, and especially for the electrophysiologist. I wish Dr. Gurmurthy could have demonstrated that too. And there is a question for Dr. Gurmurthy. Uh, can anyone read the question for Dr. Gurmurthy?
Yes, there is a question that whether these ICE catheters are disposable or you can reuse them.
Yeah, that's the
So
question.
that was my query also after listening to the talk. It was, and I would like to congratulate all the speakers. They spoke so well. They with very beautiful videos. It was very nice session to be a part of it. Anyway,
thank you,
Dr.
Gurmurthy.
Gurmurthy.
Thank you, Dr. Vijayalakshmi. Such a pleasure to be in the same virtual room with the greats like Dr. Vijayalakshmi. Thank you for this opportunity. To answer that question, when you try to compare costs with the ICE catheter and TE, especially in the United States, things become very complex because the environment here is complicated by what is the actual price of the catheter versus the payer mix, what is the contractual agreements with the hospital for paying, what kind of insurance. So it's quite complex to try to determine what is the actual cost to the hospital or to the patient. But if you look at the cost of the catheter itself, ICE catheters, both the Boston, the VFlex Extra from Abbott, as well as the Siemens Accuson, are somewhere between $2,500 to $3,000 each. And the Abbott does not, Abbott clearly mentions that you cannot reuse the catheter, so it becomes very difficult when the company says you cannot reuse to reuse. The Siemens Accuson catheters, there is no recommendation by the company to whether reuse or not reuse, and there are private companies which actually re-sterilize the catheter. But in reality, you can only re-sterilize them about 2 or 3 times, after which the quality of the images starts going down. So the Siemens Accunav catheter is, in practice in our hospital at least, re-sterilized and reused up to 3 times. But the VFlex Extra, we cannot re-sterilize because it's a clear instruction from the company not to do. The cost of the catheter itself is offset if you do not use anesthesia, at least here in the United States. If you use anesthesia, which is the majority of the times we do in pediatric patients, and you add the cost of the ICE catheter, because TE can be reused as long as you want, right? So that is where the cost offset is. So I think the cost benefit of ICE only happens if you're not using anesthesia for TE.
So how do you sterilize these catheters? They must be very delicate ones. 8 French you mentioned somehow.
Yes, I cannot speak to the exact method of sterilization, but it is there is only one company in the United States that specifically sterilizes the ICE catheters. I can
like we use glutaraldehyde for the TE probes actually, and you sterilize in the same way?
I would imagine. I'm sorry, I don't know the exact details.
Okay, no problem.
Or gas sterilization.
I think maybe there is two different things. TE goes in the esophagus, whether this ICE goes into the cardiac. So the sterilization is very, very important here. So
yes,
that's
what
very subtle thing. And apart from that, the ICE has got the 3D and the 4D, and which is used more by the electrophysiologist. And I think that has made it more useful for the electrophysiologist. And as a result, but in India, why the ICE has not become popular is, one, because of the 8 or 9 French, the children, we cannot use it. The 2, added cost. And we Indians are very good in reducing the cost. We don't even use the TE or the ICE. We do just transthoracic, that too in the epigastric view. And
that's true.
That, yeah.
To an extent,
Dr. Hiramat, instead of the femoral vein to go with the 8 French, have you used it directly through the RA after putting a sheath in small children? I see.
No, we haven't done that, Dr. Keshavamurthy, but that is something that is done. I participate in several industry device development, in which case we have even put it in the aorta. And if you put the ICE catheter in the ascending aorta, the views that you get of the aortic valve and the VSTs are the most beautiful views. So ICE is definitely very advantageous like that, but we got to work around some of these limitations that are being discussed here for sure.
Because it has got a very promising picture as far as young blood is concerned, who want to say why PA band, we have to do a regular surgery for this case. This valve is correct, that is correct. So at the end of the day, you need to show it to them what is lacking in the total correction. So if in a small child, if you can put it through the RA after putting a sheath and trying it like what we put the SPC or the IVC cannula, it will be of very great help, I think, if you have tried. In the OR.
Fascinating for sure.
Because Shanti spoke very well about epicardial. According with our experience, it becomes very difficult to direct the surgeon, that too in a small child with 3 kgs, to keep that probe in position. We do not have the small probes. It's a medium-sized probe. And slight movement with every contraction, it moves away and you cannot get a good picture. And it takes away the interest and the patience of the surgeon. So what we have done is we have put the pediatric or the adult TE probe in the sheath, put it in the pericardial cavity, anti-flexed it. So you get a multiplane angle, and we have visualized the post-correction in children with 3.5, where we could not put it through the esophagus. Shanti, that was all speakers. It was a very nice talk. Yeah, madam, continue with the discussion.
Yeah, Keshav, it's been such a wonderful journey both of us have together for almost 20 years, getting to know you, and your work ethics in the OR is just fascinates me and keeps me on my toes. I scrub in, Keshav. I have a fellow or anesthesia, one of the anesthesia will, but most of the time I have a fellow learner, and I scrub in with the surgeon. So he gives me 2 minutes of his time, and then I quickly go and you have to get the trust and it's a sibling relationship that goes on in the operating room, is what I can say.
That's nice.
Dr. Varun Agarwal, that was a very fascinating presentation you made about the advanced imaging in congenital heart disease. However, I was surprised to see that you have not mentioned about the blood speckling as well as the 4D echo. And here in India, the GE has given a 4D probe, and I would, if the time was there, I would have shown you. They are much better than any other imaging modality. It is like a histopathology with the dynamics, actually looking into the heart, and that would have been very nice. And there is a question for you, that is why the drug-eluting stent has to be used for the PDA, and during the corrective surgery, can it be taken out, while ligating the PDA? And this question is by Dr. Naveen Kumar to Dr. Varun.
Yeah, no, thank you, the organizers, and good evening, everyone. It's a wonderful opportunity, and I've enjoyed all the sessions that I attended. So it's a wonderful, it's an academic feast. Yeah, I agree with you, Dr. Vijayalakshmi. I personally am not an imager, so I don't have a personal experience with 4D flow and speckle imaging with the echo. But we do have started to look into that, especially as you mentioned with the GE machine and the 4D flow. It's still in research purposes. It's not, at least in the United States, we've not started using it for clinical decision making. But that's one of the things. In addition to, I did not talk about computational fluid dynamics as well. Shanti briefly mentioned about it. So that speckle Doppler imaging, in addition to computational fluid dynamics, I think would be the 2 major things that would be coming up in hopefully in the next decade or so into clinical practice. So, but those are definitely, and in addition also, like if people are doing advanced MRI imaging, there is a 4D flow MRI imaging as well now. So it can be combined with some of the invasive data that we get in our cardiac catheterization laboratory, and combination of all those things is probably the best thing for the patient. I'll come to your question about drug-eluting stents. So this is a very commonly asked question. So whoever asked, thank you for this question. Why using drug-eluting stents versus bare metal stents? Initially, we were using bare metal stents, and when we stented the PDA or the ductus arteriosus for ductal dependent pulmonary blood flow. And what we noted was this ductus is not normal vascular tissue. This ductus is supposed to close on itself, right? So the rate of in-stent restenosis till their definitive surgical operation, which is only like 3 to 6 months afterwards, it's much higher than you would imagine in coronary arteries or any other vessel that you put these stents in. So the re-intervention rate in these patients was as high as 30%. So re-intervention for clinically significant sinus because of in-stent restenosis. And what we have published very well, and one of the papers that I led was published in American Journal of Cardiology. And we have shown that if you use drug-eluting stents, which are coronary stent platforms, these are not specifically made for pediatric patients, but these second generation drug-eluting stents reduce that rate of in-stent restenosis and the rate of re-intervention needed for these patients. So that's the advantage of using them. The second part of the question is the surgeon. I have been in many of these cases when the surgeon goes back in there and either does the corrective operation or the Glenn operation of the superior cavopulmonary shunt, because I was curious how they take it out. But it's actually very easy. These stents are very, very malleable. So what they do is they use their forceps or something just to grab the aortic end and put a clip or ligature on there and grab the pulmonary end on the same way and then ligate the ductus from. It was much easier than I would have thought. Sometimes they take out some of the portion of the stent as well. If definitely sometimes these stents, they do protrude into the pulmonary arteries. And if that happens, then they remove the stent and patch those pools.
Yeah.
Yes, just small addition to what
cardiologists are good in putting the stents and surgeons are good in removing. Even the RVOT stenting, we put it and then just remove it. And I was very happy to see John Bass in your thank you slide, after 20 years, it was a pleasure seeing him. Yeah, please, Dr. Keshavamurthy.
We have done around 170 RVOT and PDA stents in the last 2 years. PDA stent is directly ligated by the surgeon, like how we ligate the patent ductus arteriosus. And we have removed quite a few of the RVOT stents because within 6 months to 8 months, they are back to the theater to be definitive correction. So these RVOT stents are removed and we have collected quite a good number. We have in fact sent that for histopathology to be published, what happens inside the stent to see it later.
And Dr. P.K. Hajra, when I saw your specimens, I was reminded of Dr. Richard Van Pra in Boston Children, an amazing collection of the specimens. Oh my God, it's mind-boggling, And there is a question for you from Dr. Murlidhar. He asks, why not ligate the left atrial appendage while doing the CABG? This question is to Dr. Hajra. Or anyone can answer that question by Dr. Murlidhar. Keshavamurthy can answer probably.
No,
I think yes, I think we should close it. We are short.
Okay, if we have to close, then let me thank all the panelists and all the speakers. And I thank Dr. Murlidhar and the organizers for giving us the opportunity to have the discussion on such a highly skilled and advanced techniques. And that too, we are not great. We are made great by a great giant like Kurt Amplatz. And, he used to make the custom-made devices for me and send it free of cost. All my world records are thanks to Kurt Amplatz, and big salute to Minnesota guys. And once Bob Anderson, he said, VJ, we have laid foundation. Now it is you Indians, you have to build the castle. And I think you guys are capable of doing it. God bless you all. All the best. Good night. Shubharatri.
Excuse me, ma'am.
Thank you all the
Please
speakers.
give me 1 minute, please.
Please.
Yes,
And
yes,
a
yes.
big
Priyanka.
big applause for all.
Priyanka, you want to say something?
Yes, sir. Yes, sir. First
Please
of all,
proceed.
thank you, sir, for making me a part of it. It was really very informative and elusive session by direct from the experts. I would say I'm a very junior person in this field. And ma'am, I had a question for Shanti, ma'am. Actually, ma'am, your interest in coronaries, I have same interests, and so for epicardial echo, ma'am, I wanted to ask, have you ever tried it in adult cardiac surgeries post CABG to directly visualize the venous grafts and their flows and their patencies?
No, we are not involved
Yes.
with adult
Okay.
medicine. But, given this COVID and Kawasaki's, we may start doing more of cabbages. I hope not. I hope not in future. It stays with the adult population. But if I go to the adult side, I will definitely make sure I get some images for you guys. There is always an opportunity, and the university team is very flexible. So I will take that opportunity in the next few months. I will try to get some for you.
Thank you so much.
Thank you, Shanti.
Thank you,
Shanti.
and a big applause.
And
for
Dr.
all.
Kiran.
Doctor, can I speak 1 minute? Dr.
Yes,
Mulli,
yes.
I would like to thank you and all the other organizers for making me part of this advanced session on congenital heart disease. The
Thank you.
topic I love.
Thank you for joining. Dr.
And
Kiran
the
has not said anything. Can I ask Dr. Kiran to say a couple of words
Kiran?
before we close off? Dr. Kiran has not said anything.
No.
Sir, there is hardly anything to say. It's a
You're
fantastic
happy.
opportunity for everyone to learn, and it's so good to see everyone doing so well and bringing us something that is very unique and hardly seen, especially in a resource limited setups that most of us work. So we know what the future lies for us and what we can tell our trainees that they can expect in future.
Thank you. Thank you, Dr.
Thank you,
Kiran.
thank you.
And Dr. Vijayalakshmi, please close the session.
Yeah, thank you very much for everyone, and you guys are doing great work, and God bless you all. Good night.
Good night.
Good
Thank
night.
you.
Thank
Good
you.
night to all. Thank you.
Night.
Thank
Good night. Thank you.
Thank you very much. Thanks for being with
you
us.
all.
Thank you so much.